Clara, this is your stage. Thank you for talking to us about ECPella.
Thank you so much, Peter, and thank you to EuroELSO for the opportunity of sharing this talk with you all. I'm going to talk to you about ECPella, or sometimes is also called ECMELA. It's the combination of peripheral VA ECMO and Impella for the treatment of cardiogenic shock patients that need ECMO and develop LV distension. We are going to be talking mainly about its indications, the physiological basis for its use, and what is the management of ECPella. I have no disclosures that are relevant to this talk. The summary of the talk is displayed now in this slide. As I said, we're going to start with the indications for ECPella. We're going to go through the physiological basis and going back to the LV physiology and explain some PV loops that will help us understand how ECPella works and how it can help the distended LV on VA ECMO. We're going to talk about the initial management of these two mechanical circulatory support devices. How do we transition to maintenance management? And once we have achieved stability and our patient is recovering from the end organ failure, how do we move from being on two simultaneous MCS devices to next stages, whether that's recovery or a durable device or decision to transplant the patient or just wait for a bit longer, bridging to decision. And lastly, I'm going to give you a few ideas about the evidence to support this combination. So there's a lot of evolving literature in the last few years about ECPella. I brought you a few flowcharts that have been published in recent papers where these flowcharts help you decide what MCS device used in every possibility of cardiogenic shock. And you will see the indication for ECPella is recurrent and very similar in most cases. And the indication tends to be cardiogenic shock patient that needs a quick restoration of systemic perfusion with VA ECMO and then develops LV distension, or we predict that is a high risk for developing LV distension. We see pulmonary edema or incipient signs of pulmonary edema, no LV ejection, meaning the aortic valve is shut and doesn't open, and there's smoke in the left ventricle, and the patient has a high recovery potential. So we want to achieve a very effective strategy to unload that ventricle quickly in that patient, and Impella is a good strategy for that. This is another very complex diagram, but I want you to focus only on the red circle again, and it's very similar. Cardiogenic shock needing VA ECMO with development of LV distension with or without pulmonary edema in a patient in whom we expect recovery. And then we, the authors of this article as well, propose ECPella as a potential strategy to deal with this problem of LV distension on VA ECMO. But how do we reach this very unfortunate situation of LV distension on a patient on VA ECMO? Well, you can see on this slide the typical circuits for VA ECMO. The left-hand side shows a peripheral VA ECMO circuit, and the right-hand side shows a central VA ECMO circuit. From now on, I will be referring mainly to peripheral VA ECMO because this is the strategy that combines with Impella, making it ECPella in most of the literature and most of the experience that we have. So in peripheral VA ECMO, what happens is that we drain blood from the right atrium, from the venous circulation, and we return it back through a short arterial cannula into the iliac artery or distal abdominal aorta. What ECMO support does is it alters profoundly the blood physiology in the heart, in the patient, and it effectively decouples the ventricle from the arterial circulation because it provides suddenly a continuous retrograde flow into the abdominal aorta, flowing upwards that will collide with the residual pulsatile flow that's coming from the failing heart. You can see this illustrated in this new picture that I've just put on the right-hand side of the screen. This residual pulsatile flow coming from the heart, from the failing heart, that will be pulsatile and only happen during systole is illustrated in blue. The continuous retrograde flow that happens throughout the entire cardiac cycle coming from the peripheral via ECMO is illustrated in red in the bottom and coming upwards in the abdominal aorta. Both flows will encounter each other in a region called the watershed region, where the flows collide. The size and the position of this watershed region will vary throughout the cardiac cycle. When the LV is extremely poor and is unable to overcome the sudden increase in the LV afterload that's caused by the peripheral via ECMO, there can be a sudden lack of aortic valve opening that causes LV distension, pulmonary edema, reduced coronary perfusion, and eventually intracardiac thrombus formation if we don't address it in a timely manner. What we're trying to do by thinking about early LV decompression in these patients, and one of the strategies is using ECPella, is we're trying to avoid these deleterious complications of the LV distension. We're trying to avoid the pulmonary edema and the Harlequin syndrome, the hypoxia that the patient can suffer, the reduced coronary perfusion and further ischemic coronary events, and eventually the most times fatal intracardiac thrombus formation. In order to understand the rational and the physiological basis for ECPella, I'm afraid we're going to have to go back to some basic physiology, ventricular physiology. And just bear with me for a second. We're going to go through some PV loops, and I hope I can make it clear and easy to follow. On the left-hand side of the screen, you have a standard PV loop of a healthy ventricle. I've shaded the PV loop in light blue so you can follow that easily. It has the usual shape of a trapezoid, this PV loop, with 4 sides, each of them representing one of the 4 cardiac cycle phases, and it has the usual trapezoidal shape with a rounded top. Starting from the right vertical side, that represents the isovolumic contraction, and then moving counterclockwise, we're going to go through ejection, isovolumic relaxation, and filling. There's a few very interesting concepts that we're going to derive from this PV loop. The first one is the what does the width and the height of the PV loop represent? The height of the PV loop represents the systolic arterial pressure, and the width of the PV loop represents the stroke volume. The PV loop falls between the boundaries of the end-systolic pressure-volume relationship and the end-diastolic pressure-volume relationship. The ESPVR, or end-systolic pressure-volume relationship, is that line that has just appeared in your screens. And it models the relationship between the end-systolic pressures and volumes in the ventricle. The ESPVR is directly related to the LV contractility. It's linear, as you can see there, and its slope is the end-systolic elastance. It reaches 0, and it reaches 0 at what's called the unstressed volume, which is the residual volume, the volume of blood that can reside in the ventricle without increasing the ventricular pressure. Any change in the LV contractility will move the ESPVR. Any increase in the contractility will move the ESPVR towards the left and higher, hence increasing the end-systolic elastance without moving the unstressed volume. That's why we say that the end-systolic elastance is a load-independent index of LV contractility. Let's look now at the next concept, which is the end-diastolic pressure-volume relationship. In the bottom is the red line that has just appeared there. The EDPVR indexes the extent of LV relaxation, is non-linear, as you can see here. What we need to remember about it is that any changes in in ventricular diastolic function or remodeling will change the EDPVR. Any decrease in diastolic function, such as what we see in infiltrative diseases, restrictive cardiomyopathy, or hypertrophic cardiomyopathy, will move the ED-PVR towards the left. Any remodeling, like what we see late after a big MI, will move the ED-PVR towards the right, hence towards larger volumes. A third concept that's very important and is derived from the PV loop as well is this yellow line that has just appeared in your screens. That's the effective arterial elastance, is the line that connects the end diastolic volume with the end systolic pressure volume point. It's related to changes in the total peripheral resistance and the heart rate. The point of there's a point of intersection of this effective arterial elastance with the ES-PVR, and this is what represents the vascular ventricular coupling. This is where your ventricular physiology and your arterial circulation physiology collide. Right, so let's look now at the right-hand side of the screen. We have again the PV loop. The PV loop helps us also understand the myocardial oxygen consumption. What I want you to remember from this screen, from this slide, is that the area within the PV loop is called the stroke work. That's calculated as the product of stroke volume multiplied by the MAP. And there's an interesting concept that you've seen in the literature surely in the last few years that's derived from here is the cardiac power output, which is a product of the stroke work multiplied by the heart rate. Cardiac power output is used more and more in the clinical practice, and it has shown to be inversely related to in-hospital mortality and directly related to positive response to the treatment of cardiogenic shock. The sum of the stroke work and the potential energy, which is this red shaded area to the left of the stroke work, is a pressure volume area. What I want you to remember from that is that any increase in the pressure volume area is going to be linearly related to an increase in the myocardial oxygen consumption. So if we all have these concepts clear, we can move towards what happens in pathological situations. So I'm going to take you through this cycle slowly, which is a cycle in which a patient's grown from being healthy to have an acute MI, going through the neurohormonal activation, SIRS, and remodeling of the ventricle, and eventually ended up on ECMO in any of these stages of his cardiogenic shock. So the normal PV loop is tall, good systolic arterial pressure, is wide, adequate stroke volume with a steep ES-PVR, so good LV contractility and a normal ED-PVR. When imagine this patient suffers an acute anterior MI and suddenly there's a sudden loss or reduction of the contractility of the left ventricle, the ES-PVR will shift towards the right and it will shift down as well as a reflection of the reduction of the contractility. The PV loop will become shorter, so the patient will become hypotensive, the systolic blood pressure will drop. It will become narrower, the stroke volume will be smaller, so the cardiac output will fall. And there will be a mild increase in the LV EDP and the wedge pressure of that patient. The natural following stage after somebody having an acute MI is these baroreceptors in the great vessels identifying that there's been a sudden drop in the arterial blood pressure. And what happens is that the neurohormonal activation kicks in. There will be an increase in the heart rate and venoconstriction. That will lead to increase in the total peripheral resistance, the increase in the circulating blood volume and the blood pressure. So there will be a shift towards the right of the ES-PVR. The PV loop will become a bit taller, the blood pressure will increase a bit more and a bit narrower at the expense of reducing the stroke volume. At some point after that, there will be a degree of SIRS, of inflammation, and the total peripheral resistance will drop, meaning that the blood pressure can drop, the systolic blood pressure of this patient will drop. The ES-PVR shifts downwards. The PV loop looks narrower, shorter, and it will move further to the right-hand side. The total balance between the neurohormonal activation causing increased blood pressure secondary to vasoconstriction and the inflammation causing reduction of the blood pressure secondary to vasoplegia will determine whether the total PVR, peripheral vascular resistance, is the same, is increased, or is decreased. The latest stage of somebody that suffers an MI is a remodeling, in which the ESPVR will move further towards the right and the EDPVR will move towards larger volumes. What happens if we add ECMO at any of these stages? So you can see here in the screen, the green trapezoid is a normal PV, a representation of a normal PV loop. So wide and tall, and on the left-hand side of the graph. When we go into cardiogenic shock and neurohormonal activation kicks in, we will have a taller and narrower PV loop, and it will be shifted to the right-hand side. If we put somebody on ECMO, we will be adding this continuous retrograde flow coming from the iliac artery up into the aorta constantly throughout the cardiac cycle. That means automatically that there will be an increase in the LV afterload. There will be an arterial elastance line shift to the right. There will be an increase LV end diastolic pressure, increase in the LA pressures and the wedge pressure, an increase in the end diastolic, LV end diastolic pressure. The PV loop will shift upwards and rightwards, as you see on the graph there, and it will become narrower and taller. There will be an increase in the PVA because of all of the above, and there will be hence an increase in the myocardial oxygen consumption and the stroke work. What can we do to avoid these problems at this stage? We need to unload the ventricle, and we need to find a strategy to unload this LV before things get worse. We have a ventricle that is distended, that has increased myocardial oxygen consumption, and that is retrogradely causing increase in the wedge pressure, pulmonary edema, differential hypoxia, and even in very fatal cases can cause a pulmonary hemorrhage. Many strategies have been described in the literature to achieve LV unloading. We can go for the basic one, which is what we all try in the beginning, which is trying some medical pharmacological management, give the patient a few more inotropes to see whether we can get the ventricle to contract, LV to contract a bit better, open the aortic valve, give vasodilators, and try to reduce the afterload caused by the peripheral VA ECMO. Offload the patient. Typically, most of these patients, especially the ones that end up on ECMO with decompensated end-stage DCM, will be grossly overloaded. Try to offload the patient and see whether the combination of that medical management can get the aortic valve to start opening and the LV-EDP to start coming down. Some other strategy, a classic strategy that has been used and published in the literature in thousands of patients, is the intra-aortic balloon pump. So you put an intra-aortic balloon pump in the aorta of that patient at the same time that you have the peripheral VA ECMO, and you reduce the LV afterload in the hope that you will reduce it enough to promote aortic valve opening and LV unloading. If none of that works, or perhaps if you don't believe in those strategies in your specific patient because you think the profound failure of the LV will not be able to reverse with that medical strategy or the balloon pump, what you can do is put an Impella in that patient. And you put this microaxial small pump coming retrogradely from the femoral artery or the axillary artery all the way across the aortic valve with the tip sitting in the left ventricle. And then you constantly throughout the cardiac cycle drain the left ventricle and return the blood into the ascending aorta. And that's what we will be explaining from now on. And that will be the combination of Impella and peripheral VA ECMO named ECPella or ECMELA. Some other people do an intra-aortic septal septostomy in some centers, and there's a few cases of published in the literature about something called lava ECMO, which is a complex peripheral VA ECMO approach that some centers use when they predict that they will run into trouble when they go on peripheral VA ECMO with LV distension. And what they do is they put a special venous drainage cannula that they insert across the interatrial septum and is multi-perforated, as you can see here, and you can achieve biatrial drainage, hence inherently achieving LV offloading at the same time that you provide systemic perfusion with ECMO. But what we're going to speak about now, from now onwards, is what do we do, what do we achieve if we add Impella on somebody already on ECMO who has LV distension. So Impella, as I said, is a small pump. It's usually inserted through the femoral artery if it's an Impella 2.5 or CP, through the axillary artery if it's an Impella 5. That's our usual approach in the center where I work. We use CP through the groin, Impella 5 through the axillary artery. It crosses the aortic valve, the tip sits in the ventricle, and it pumps blood constantly and continuously throughout the cardiac cycle from the left ventricular cavity into the ascending aorta. It achieves an immediate and sustained LV unloading and is titratable. You can titrate the speed of the pump to achieve higher or lower flows. Percutaneously inserted through the femoral artery by the interventional cardiologist in our center, an Impella CP. The Impella 5 needs a surgical approach. The roles of the ECPella are three mainly. We're going to increase the cardiac power output, we're going to increase the oxygen supply, and we're going to decrease the myocardial oxygen consumption. How do we do these things? Well, we add in a third flow to this patient. Remember, that patient had pulsatile flow coming from the failing left ventricle, a retrograde continuous flow coming from the iliac artery, from the return cannula of the ECMO. And now we're going to add a third flow, which is a continuous flow coming from the left ventricle into the ascending aorta, and that's provided by the Impella. And that will cause an increase in the cardiac power output. This level of the degree of increase or improvement will depend on the P level, meaning the speed of the pump of the Impella that we choose, and the gradient of pressure between the aorta and the left ventricle. Because we are directly draining from the ventricle and returning blood into the ascending aorta, I'm sure that you have already guessed that the pressure in the aorta will increase dramatically in patients on Impella as soon as you start as the Impella starts functioning. And that will cause an increase in the oxygen supply because we increase the ascending aorta pressure, so your coronaries will be well perfused. And because you are actively draining and offloading, unloading the left ventricle, you will cause a direct reduction on the LV EDP and the LV EDV, the left ventricular end diastolic pressure and volume. That will reduce the wall tension of the ventricle. That will promote recovery if that's what we are hoping for. There will be also another effect of adding Impella to these patients. There's a quick reduction in the oxygen demand because we are reducing the left ventricular dimensions and pressure straight away. We are reducing the LE pressure and the wedge pressure, hence reducing the myocardial wall tension and the mechanical work. So the total balance of oxygen demand and delivery becomes favorable. When we look at the PV loops of somebody with a ECPella, you can already see here in the red one on the left-hand side that the shape has changed. Why does the shape go from a trapezoid to a triangle? Because we have lost the isovolumic periods. There's no such thing as isovolumic periods because the drainage of the ventricle is constant. Throughout systole, throughout diastole, there are no isovolumic periods. So the shape changes and the PV loop moves down and to the left-hand side. There will be a reduction on the pressure volume area because the PV loop is going to move to the left-hand side and down. And hence there will be a reduction on the myocardial oxygen consumption, improving the blood oxygenation, the systemic pressure, the perfusion, and leading to beneficial secondary changes in LV contractility and SVR. There will be an increase in the total blood flow because we add in this new extra anterograde flow, continuous flow coming from the heart into the ascending aorta. And we will be reducing the wedge pressure because we are actively unloading the left ventricle. And there will be an increase in the pulmonary artery capacitance that exceeds the reduction in the PVR. That increases the PA constant, reduces the RV afterload, and increases the right ventricular systolic volume. The only potential problem with all of this of increasing the forward flow from the left ventricle, initially in a patient with LV distension, is if you've left it too long and you have full-blown Harlequin syndrome, you will have a sudden degree of deterioration in the level of the Harlequin syndrome, because you will have a new forward flow coming from the heart, coming from the pulmonary circulation of deoxygenated blood. So you have to be really careful about applying the ECPella in time and not when you have full-blown Harlequin syndrome, because that will cause worsening of the hypoxia of the patient. This is a representation of PV loops and pressures in the aorta and wedge pressures on how we go from cardiogenic shock to ECMO to ECPella. So figure A is a patient with a normal PV loop in black. Then how that PV loop changes to when we go into ECMO. It becomes taller and narrower. When we put the patient on ECMO, there's a sudden increase in the LV afterload because we have this new retrograde continuous flow into the aorta. So the pressure in the aorta will increase, and the wedge pressure will increase because there's an increase on the LV afterload. When we add Impella, we go into ECPella, the PV loop shape will change. We lose the isovolemic periods. The trapezoid becomes a triangle, and then the pressure in the aorta increases even further because we have this new flow, this time anterograde continuous flow going into the ascending aorta. But because we are actively and effectively unloading the ventricle, your wedge pressure will drop. So potential advantages of ECPella, there are many of them. You have effective LV unloading. Your LV EDP and your LV1 tension will decrease straight away, and your LV work and myocardial oxygen demand will decrease straight away. You have an increase in MAP, so improved systemic perfusion, improved diastolic blood pressure, cardiac output, cardiac power output, systemic perfusion, and coronary flow. You have improved coronary perfusion because you have improved pressure in the ascending aorta and improved unloading of the ventricle. Your wedge pressure and your RV afterload will drop. It's less invasive than transatrial septostomy, and in centers that use Impella regularly on its own, either as an umbrella for high-risk PCIs, or you use it for large-sided MIs, left-sided MIs. It's just adding a device that you feel familiar to a patient who's already on mechanical circulatory support. It's titratable, which is very important, and is a big difference with the previous strategy of using balloon pump. You can titrate the amount of LV unloading that you want to achieve in these patients. And it achieves unloading even in profound heart failure. So even if the patient is not ejecting at all and you have a completely flat arterial line, you can still achieve effective and continuous unloading of the left ventricle with the ECPella, sorry. Disadvantages, many of them, of course. It's not available everywhere. Malposition and migration is frequent. Whoever in the audience who is familiar with Impella will know how frustrating things can be sometimes when there is initial malposition of the device and it gets tangled in the anterior leaflet of the mitral valve or the papillary muscles, or it tends to migrate up and down in the ventricle or even out of the ventricle. And this is relatively frequent, and when it happens, it tends to happen more times in the same patient. And resolving an initial malposition when the Impella doesn't go well into the LV cavity, in the center of the LV cavity, and it gets in really close to the anterior leaflet of the mitral valve, is sometimes extremely challenging. Hemolysis happens also frequently because of malposition, because of migration, or sometimes happens because we have missed that there's been a change in the LV end diastolic volumes and we have kept the same level of speed of the pump. and then the the Impella becomes too close to the interventricular septum, and that can cause suction events and hemolysis. Minor bleeding from the insertion site is very frequent as well. It usually can be treated by the bed space with an extra stitch, or the cardiologists having a look at it, but minor bleeding is frequent and sometimes problematic. Limb ischemia can occur in patients with peripheral vascular disease, and then if you run into a very long, prolonged Impella course, especially if you had bleeding issues in the insertion site in the beginning, or if you've had to reposition the device quite a few times, you can have an increased risk of infection from the insertion site. So potential disadvantages, there are many as well. This is not as easy as it can sound. So what are the hemodynamics of somebody of ECPella? So I've already hinted you with the complexity of it. We have 3 different flows coming and colliding into the aorta somewhere in the watershed region. We have continuous anterograde flow coming from the Impella, coming from the left ventricle into the ascending aorta. We have the residual pulsatile LV flow coming from the failing heart, if there's still any, if the LV hasn't stopped contracting fully. And then we have the continuous retrograde flow coming from the peripheral VA ECMO, somewhere into the iliac and ascending up into the aorta. The 3 of them will collide and will find each other in the watershed region. This time the watershed region will probably move less because there's less pulsatile flow. There's a predominance of non-pulsatile or continuous flows, and perhaps some authors say that that will lead to less chaotic flow in the aorta and perhaps to an earlier recovery of end organ failure, although that's not been proved in the literature so far. So how are pulsatility, preload and afterload determined on a patient on ECPella? Well, pulsatility will depend on the LV pressure waveform, and that will be determined by the remaining LV contractility and the loading state of the heart. So whether there's how profound the LV failure is and how well loaded the heart is. The preload will depend directly on your ECMO and Impella flows. The preload will reduce if you increase your Impella flow, because you will be draining more blood from the left ventricle. And your preload will also reduce if you increase your ECMO flow, because you will be bypassing more heart from the cardiopulmonary circulation. The afterload will be determined also by the devices, and also the afterload will itself determine will impact the devices. Remember that these devices will work worse with hypertension because they will have to fight the hypertension of the patient. So afterload will be incredibly important, the management of afterload, when finding the right balance in patients on ECPella. So how do we manage, what's the initial management of these patients? First, remember, we will usually have the ECMO inserted first and the Impella inserted immediately after if there is catastrophic LV distension during ECMO insertion, or if we have predicted that that will happen. Or perhaps we put the Impella a few days later if the LV distension occurs slowly, or we're using ECPella as a bailout strategy. But once we are on ECPella, we will use the ECMO to provide systemic perfusion and the Impella only to unload and protect the left ventricle. So we want high ECMO flows because we have typically a patient in cardiogenic shock for some time, developing incipient end organ failure with signs of global hypoperfusion. So we use high ECMO flows, decent ECMO flows to provide systemic perfusion. We want a map of around 70 millimeters of mercury, SVO2 ideally around 60% or above. We want to see our lactate decreasing, showing us that we are providing systemic perfusion, adequate systemic perfusion for our patients. And then this is the moment, the immediate post-ECPella insertion, to think about, have we done it too late? Are we on full-blown Harlequin syndrome? Do we need to change our VA ECMO circuit to a VAV ECMO circuit? If we don't, we carry on. So we have a high ECMO flow and a low Impella flow, which I'll speak to you in a second about, just directed towards a load in the ventricle. We want a map of around 65 to 80 millimeters of mercury, not above that. Initially, our patients can become incredibly hypertensive in the beginning, and we might need to use dilators to bring that map down to allow for the devices to work properly. But without a doubt, in most of the cases, what you will see as the hours go by is that the patient shifts towards a state of vasoplegia or vasodilatation, and you start to have, you need to start using some vasopressors, which is okay. Then we will titrate the Impella flows against echocardiography. We typically start at P2, so a low speed of the Impella. And we echo the patient and we make sure that the position in the Impella is right, that we are not too close to the anterior leaflet of the mitral valve, that we are well centered in the ventricle, that the distance into the left ventricle is adequate from the aortic valve, and also that the interventricular septum is in the middle and that we have reduced the LV end diastolic volumes and diameters. And we gradually increment the speed of the pump, the P of the Impella, to achieve the adequate echo features and clinical features of LV unloading. When do we know when we have reached that disbalance between the two of them? Well, we have suction alarms from the Impella. We will have hemolysis from the Impella, or even if we are over unloading the left ventricle and the Impella catheter is touching the interventricular septum, we can have episodes of ventricular arrhythmias. Then we have to navigate the ischemia reperfusion injury. As I said initially, you can see some hypertension when we go into the dual MCS support, and then the patient shifts toward that state of vasoplegia, and then we have to allow for hours or days for the end organ failure or dysfunction to improve slowly. Once we have achieved some stability, is the time to start thinking about removing fluid with diuretics or hemofiltration, whatever is indicated in each case, but only when the hemodynamics allow. The first hours are probably not good hours to start doing that. How do we find this right balance between the two devices? So as I said, we need high ECMO flows and then the lowest Impella tolerated flows to try to reduce the risk of hemolysis or complications. What do we use to guide us to find the right balance between the two of them? Apart from the clinical examination or our clinical expertise, we need to use echocardiography and data from the Schellongowski catheter daily. What do we do on these daily echoes on the patients on Impella? We look at the end diastolic volumes and diameters, and we look at reduction. We're hoping for a reduction of the end diastolic volumes and diameters, obviously, from before the Impella was inserted. We make sure the Impella hasn't migrated, and also that it's not becoming too close to the interventricular septum when we are achieving enough unloading. We want to predict suction events. So when you are over unloading the left ventricle, you have to come down on the Impella speed or come down on the fluid offloading of your patient to make sure you don't run into trouble with suction events. You want to monitor the diastolic function, make sure it improves as the Impella support goes on throughout the days, and you want to look at your right ventricle and your typical echo monitoring of your right ventricle. Typically, we would have a Schellongowski catheter in these patients. Again, for monitoring, we use continuous SVO2 monitoring. You want an SVO2 of 60 or above, as I said. We use the wedge pressure to monitor the effectiveness of the LV unloading from the Impella. We use the PAPI, the Pulmonary Artery Pulsatility Index, and you can use the ratio between CVP and wedge pressures to assess the how balanced they are, the flows of the two MCS devices. We have achieved stability. We're happy. We're navigating the ischemia reperfusion injury, and our patient is starting to stabilize. So what do we do then? We have three types of patients. We have the patients that we put as a bridge to decision and we put in a hurry, we were not sure. And then these patients will have to wait to see what they do, whether they get better or they don't, to try to transition them to any of the other two groups. We have the patients that we put on ECPella as a bridge to recovery, typically young myocarditis patients, ECPR patients. Or we have the patients that we bridge to durable VADs or heart transplants, typically decompensated end-stage DCMs that end up failing to respond to medical management in ITU. So now that we have these three types of patients, how do we win them? Because they are on dual MCS support, definitely this cannot be the case for long enough before we run into complications. So how do we win these devices? In the bridge to decision, we have to wait, and we have to wait and see where the patient goes before we can help decide which device we're going to win first, if any. In the bridge to recovery patients, as soon as we achieve stability and the end organ failure starts to resolve, we need to try to win the ECMO first, by all means, followed by the Impella. Everyone familiar with ECMO, VA ECMO in the audience will know that after the honeymoon period, after a few days, you start running into trouble. So you want to win your ECMO first and leave the Impella in, and then win the Impella at a later stage. When you're bridging these patients to a durable VAD or a heart transplant, perhaps all you have to do is win the ECMO and then leave the patient on Impella waiting for this durable VAD or a transplant. And perhaps what you want to do is upgrade this Impella CP that you put in a hurry in the beginning to an Impella 5 in the axillary artery, so they can deambulate and rehab and walk around the unit whilst waiting for their VAD or their heart transplant. So let's think that we have a patient that we are bridging to recovery, because that will be the most common one. And let's see how we win the ECMO first, followed by winning the Impella. So that's how we would win ECPella. Win the ECMO first, followed by winning the Impella later. When do we start winning? And this is very common sense, and we all know how to do it. We need to wait for improved hemodynamics, resolving parameters of cardiogenic shock, low doses or very minimal doses of inotropes and vasopressors, favorable hemodynamics in the winning studies that we start to do on our patients, and no other complications present. Once we are in this steady state, we can think about winning. In order to win ECMO in a patient and ECPella, we're going to use the classic criteria to start winning ECMO. We're not going to do anything differently. We want a patient phenotype to be favorable, compatible with recovery. We want recovery in organ function, adequate systemic oxygenation, a good PAFI, and low levels of vasopressors and inotropes. And then we're going to use a combination of echocardiography, clinical assessment, and data from the pulmonary artery catheter to assess whether a patient is ready to win from ECMO. The classic approach to ECMO winning has three different stages. Once we decide that a patient is ready to be assessed for winning, we will do a bedside daily winning study in the unit. What we do is we start reducing the ECMO flow by ½ liter per minute and wait a few minutes at each stage. We look at the map of the patient, we look at the intracardiac pressures, and we do an echo of the patient. We want our map to remain stable and not to drop by more than 10 millimeters of mercury. We want our intracardiac pressure, CVP, and wedge to remain stable. And we want our echo features that I'll tell you in a minute to remain stable. We carry on coming down by ½ liter of ECMO until we reach the 2 liters per minute mark, and we don't go below that. If everything looks favorable and the patient remains stable, we leave our patient on VA ECMO flow of 2 liters per minute for at least 8 hours before we make further decisions. Why do we say 8 hours? Because we've all seen patients that tolerate weaning for a few hours and then fall in asleep in the middle of the night. So we want to avoid making too early decisions about these patients on such a complex mechanical circulatory support. We use bedside echo measurements and pulmonary artery catheter measurements throughout these 8 hours to ensure that we have stability. If the patient fails, if the map drops by more than 10 millimeters of mercury, the intracardiac pressure goes up, or the echo features are unfavorable, we go back up to the initial ECMO flow and we try another day. If it's successful, what we do the following day is we drop the flow, we check the anticoagulation first, whatever you use for monitoring anticoagulation, anti-10A, ACT, APTT, you make sure you're well anticoagulated and you drop the flow from 2 to 1 liter of ECMO flow for a minute and you make quick measurements. And then you make sure they're favorable. If they are, you go back up to 2 liters per minute and you start making arrangements for decannulation. Decannulation of peripheral VA ECMO needs to happen in theaters in a timely manner because most of the patients will require repair of the femoral artery and they require for sure an embolectomy of the leg to avoid any further complications. What echo parameters and pulmonary artery catheter parameters we will be looking at when weaning ECMO in a patient on ECPella? We will be looking at the classic ECMO weaning parameters. We want, when the ECMO flow is down to 2 liters, we want an LVEF greater than 25%, mitral S prime of 6 centimeters per second or above, and an LVOT VTI of greater than 10, 12 centimeters. So those are the classic parameters which I'm sure you've seen in every standard VA ECMO weaning protocol. There's this very interesting article that was published last year in the Journal of the American Society of Echo, where they, for the first time, used pretty load-independent markers of echocardiographic markers to predict successful weaning from ECMO, which I think is especially relevant when we're weaning from ECPella, because your preload will change dramatically when you start reducing your ECMO flow if you haven't changed your EPella flow. So they saw in this article that any improvement in the lateral E prime velocity and a 10% of the improvement in the tricuspid S prime velocity when reducing the ECMO flow by 50% was related to successful ECMO weaning. And this is incredibly interesting because for the first time, these markers are first load independent or pretty preload independent, and also they reflect diastolic function of the left ventricle and systolic function of the right ventricle, which were pretty much forgotten on the classic echo predictors of successful VA ECMO weaning, and perhaps explain having ignored these factors in the past, explain why some patients failed ECMO weaning despite theoretically positive echo features of ECMO weaning. The other parameters we're going to use to predict whether a patient is going to wean from ECMO when they are in ECPella is parameters coming from the pulmonary artery catheter. And what we use is cardiac power output. You want a cardiac power output of above 0.6 when you are on low ECMO flows, 2 liters per minute. You want your wedge pressure to remain stable, and you want your PAPI, your pulmonary artery pulsatility index, to be above 0.9. to feel a bit more comfortable that that patient is going to wean from ECMO well. So imagine we explant the ECMO and we remain on Impella and our patient is recovering. There's some degree of LV contractility that's getting better. How do we wean this Impella? So we are only on one mechanical circulatory support device at the moment. What we're going to do is we're going to use very standard readiness to wean criteria. We want the patient to be hemodynamically stable on very minimal inotropic support. We want our ventricle to look better on lower speed of the pump, and we want a pulsatile arterial trace for at least 24 hours. The safest way of weaning Impella will be doing the slow approach, especially in a patient who's had such a complex journey as to go through ECPella. And the slowing protocol proposed by some authors in the literature consists on a gradual pump speed reduction by 1-2 P levels every 4 hours, and continuous reassessments with echo and Swank's catheter data until we reach P2. And then that patient needs to stay on P2 stable for at least 8 hours again before we think about explanting the impella. So we again look at very similar parameters. We want the standard or the classic echo predictors of the successful ECMO win. You want an LVF greater than 20-25%. You want S prime greater than 6, and you want an LVOT-VTI greater than 10-12 on P2 of impella before you decide to explant. Luckily, this time the patient can be explanted in ITU without going to theaters unless there is severe damage to the femoral artery. There was severe damage to the femoral artery during insertion, which is very rare in impella nowadays. So then, luckily, we would have wind from both devices, and a patient can carry on their journey. Right, so what is the evidence to support this combination, this ECPella? I brought you a few articles that I thought were interesting and also shows the evolution of how we have managed to reduce the complications related to mechanical circulatory support in centers who have large volume of NCS throughout the years. So this is the first article is a retrospective paper published in Circulation in 2020. The patients come from an international registry, and it's relevant that they have been collected throughout 15 years, and they are very old cases here from 2005. The study compares ECPella versus ECMO for cardiogenic shock, and the primary endpoint is 30-day mortality. The study was able to demonstrate that despite the mortality being really high, it was lower on the patients on ECPella, but at the expense of a higher rate of complications, mainly related bleeding, ischemia of the leg, abdominal compartmental syndrome, and the use of RRT. I think this is becoming less and less common in the literature, and the reason why, and this is my personal interpretation, why they have such much higher complications then, is that these are the early ages of the use of impella in the States and in Europe, where people were at the very beginning of the learning curve and the rate of complications were extremely high. And also in general on VA ECMO, the rate of complications continues to decrease, and we're becoming better at monitoring the anticoagulation, at the access, at managing and preventing leg ischemia, and also at managing AKI. This second paper I bring you is a meta-analysis published last year, includes many patients, 13,500 patients. Again, comparing ECMO versus ECPella, including patients from 2016 to 20, so a much more recent studies, and end stage, and the primary endpoint is mortality again. Again, ECPella demonstrated reduction in mortality versus just ECMO on its own. Major bleeds are once more more frequent in patients with ECPella, and interestingly, patients with ECPella are bridged less to long-term therapies, which the authors interpret that perhaps they recover better. The last paper I bring you is an American paper published recently, and this paper again compared a VA ECMO cohort with an ECPella cohort. 36 much lower numbers this time, and the primary endpoint is again 30-day mortality, secondary endpoints complications, and 1-year mortality. The results are shown in the next slide, and the results are quite shocking really, because this time they managed to almost halve the mortality in the patients on ECPella at 1 month, and also triple the survival at 1 year of the patients on ECPella. And there were no statistically significant differences in terms of bleeding, AKI, use of RRT, and stroke and TIS, which are very shocking and perhaps very optimistic results of this study, although as I said, the numbers are very, very tiny. So it's only 30 patients in each group. So conclusions, I brought a few. I'll start with the negative ones. It's hard to get away usually with just medical treatment or a balloon pump in patients that need peripheral VA ECMO with very bad LVs. The medical management is usually insufficient. The Impella learning curve is long and cumbersome and sometimes really frustrating. And there's an increased rate of complications. Mainly, I think nowadays that we do a lot of it, we see a lot of minor bleeding from the insertion point and hemolysis related to either clotting of the pump or a suction event. The positive conclusions from the talk is that ECPella clearly achieves an immediate and very effective LV decompression, and it stops this terrible spiral of LV distension, pulmonary edema, ischemia of the coronary arteries, Harlequin syndrome, and intracavitary thrombi formation. Allows for earlier ECMO decannulation, which is all we hope for. As soon as you put somebody on ECMO, you're just hoping to decannulate them before they run into travels with VA ECMO, and then allows ECPella to a potential transition to an Impella 5 in a patient whom you're bridging to a durable VAT or a heart transplant. And if you have an Impella 5 in the axillary artery later, you can start deambulating, rehabbing whilst waiting for your long-term support. That's the end of my talk. Thank you very much. I will take questions now.
Thank you so much. That was really an awesome presentation. Thank you so much for taking us all the way from the physiology, which was very clear. I, for myself, can say that when this webinar is broadcasted for download purposes in a couple of days, I will definitely have a second look at everything, so I can make sure to get even more than I got the first time. Throughout the way up to the exciting clinical data that you showed, at least in the observational studies. Very, very great presentation. Thank you so much.
Thank you.
The time is quite advanced. However, we still have a record high number of participants and many questions coming in. So if you agree, I would like to keep it a bit further and
Of
really try to drain you a bit more and get everything that's so burningly interesting to all of us. So I would like to start with the clinical data that you showed in the end. Now, given that you said a good indication would be pulmonary edema on VA ECMO and LV distension, did these studies more or less include kind of these patients, or were these also studies that also included any kind of acute heart failure on ECMO?
So especially the American one, the last one, what they did is they put the patient on ECMO for cardiogenic shock, and then they waited. Some of them will develop LV distension slowly throughout the next 24 hours, and that's when they decided to go on ECPella. And some of the other patients had very poor LVs to start with, so they predicted that they will develop LV distension straight away, so they went for ECPella straight away. So there's a variability between the cases, but as I said, they didn't wait too long to go into ECPella, so less than 24 hours or around the 24-hour mark after going into ECMO, which probably explain the excellent results that they had with ECPella.
Okay. Now, when we talk about the indications that you suggested, how do you define distension? What are your cutoffs to say this patient is in distension and this one is not?
So we measure wedge pressure, or sometimes we when we do insertions of peripheral VA ECMO in the cath lab, the interventional cardiologists measure the left ventricular end diastolic pressure. If it's high, immediately after going on ECMO and it's unreasonably high, we know that we're not going to be able to reverse that. And you have a ventricle that is dilated with the aortic valve that's not opening in every cycle on starting to close with very minimal ejection through the aortic valve. That's when we decide that we need an effective strategy for LV decompression. So if we have an PA catheter in beforehand, we measure the wedge pressure. If there is a sudden increase of wedge pressure with very poor LV function, intermittent aortic valve opening, that's when we go for it. We don't wait for patients to develop pulmonary edema.
Okay. Now, I'm not quite sure. Some centers who will do BA ECMO in acute heart failure may not be using PA catheters. Are there any substitutes that we could use in terms of echo criteria that could tell us the same thing as the pressure measurements that you mentioned, Clara?
Definitely. I mean, there's a lot of estimates of wedge pressure by transthoracic echocardiography in the literature, and that those could be used for the patient on ECMO. You can look at the diastolic function, you can look at the worsening of the MR on these patients, and even if you're not able to estimate precisely a wedge pressure on echo, if a patient is stopping to open the aortic valve and the ventricle is full of smoke, you have clear indications there that you're not unloading the ventricle and you're going to run into trouble. So even just simple 2D imaging of the heart can help you to decide whether you need LV decompression. And that can be done by the bed space at any time.
Okay, maybe one last question on that topic, because some of us may be thinking about going into this technique without having used PA catheters lately on a regular basis. Did some of the clinical studies that you showed to us include centers that did not on a regular basis do either invasive pressure measurements in terms of PA catheter or even measurements in the lab?
Yes, some of the studies only talk about echocardiographic features of LV distension and signs of worsening diastolic function, worsening MR, worsening smoke in the left ventricle. So I think echocardiography will be sufficient to guide you on the indication for using ECPella. I think it's just interesting or a bit more reassuring to have exact numbers of how your wedge pressure comes up and down when you start ECPella. And we, in our cardiothoracic unit, we are very pro using PA catheters for the postoperative care of cardiac surgery and most of our patients. So we are very familiar with PA catheters, but definitely you don't need a PA catheter if you're an expert echocardiographer to manage these patients. Yes.
Okay. Now, there's a second section that I wanted to ask you about in terms of indication. How about what's the role of positive end expiratory pressure in these patients? When you mention one of the criteria is a clinical one, it should be pulmonary edema, right? Mm-hmm. So if we apply PEEP, this will mess with many of these measurements and also with the clinical presentations. What do I need to consider?
So I think if you have pulmonary edema in these patients on the X-ray, but you still have ejection through the aortic valve, and you manage to start some vasodilators, reduce the afterload, even start some inotropes, and you manage to maintain AV ejection, you can treat them normally with CPAP, BiPAP, or intubation and see an offloading and see how they go. But I think if you reach the state where you have radiological findings of pulmonary edema without ejection across the aortic valve, positive pressure or non-invasive ventilation will be insufficient.
Okay. Now, there's a question of one of our participants who writes that he has witnessed that some of these patients in pulmonary edema, once they go to additional Impella support, their already somehow manifest Harlequin syndrome may at first become even worse. and you mentioned the role of Harlequin syndrome in these patients. What's your tip on how to counteract that and how to deal with that situation?
I think if you have full-blown Harlequin syndrome before you go into ECPella, you're going to run into very severe problems. And perhaps what you should think about is transitioning from VA to VAV, and then add the extra flow of the Impella. When you have manageable pulmonary edema with acceptable oxygenation, even on high FiO2, then you can go into ECPella, because you know that for a few hours things are going to look rough, but you're going to be able to unload the ventricle and decompress the pulmonary circulation. But if you are on full-blown Harlequin syndrome, already suffering a severe degree of upper body hypoxia, adding an extra Impella is just going to make things worse. So perhaps you need to think about adding an extra venous cannula to your initial VA ECMO and convert to VAV.
Okay.
That's why I think, once you put somebody on peripheral VA ECMO for profound cardiogenic shock, the initial hours when there are signs of LV distension are really critical, because if you're going to use ECPella, you have to use it early before it's too late and before you are on severe Harlequin syndrome.
Okay. Now, I was going to ask you some questions about the complications. However, you showed some of the rates reported in the study, so I think we can skip that. Maybe just one thing, you mentioned hemolysis, right? Two questions concerning that issue. The first one being, how does ECMO change the anticoagulation strategy to a ECMO mono application? And the other one would be, how do you tell apart if hemolysis comes from the Impella? And I suppose that's the higher likelihood that it comes from the Impella, but how can you rule out it comes from ECMO? So anticoagulation and that.
So the anticoagulation, the difference is that you will always have to give some anticoagulation, some heparin diluted in glucose, 5% glucose, through the purge line of the Impella. And the usual dilution is 25,000 units of heparin in 500 milliliters of glucose through the purge line of the Impella. And you do that, the Impella self-regulates the purge pressure line, and that will provide anticoagulation of the cannula, the Impella cannula in its own. And then we use the same anticoagulation target for ECPella, that for ECMO or Impella on its own, and we aim for an antitennine level of 0.3 to 0.5 in the absence of complications. So the only
all the heparin goes through the Impella itself?
No, so some heparin goes through the Impella, and that's the purging line of the Impella. So and we don't monitor that, and we always use that. And then we use systemic heparin on top of that to achieve an antitennine level of 0.3 to 0.5, which is our standard level of anticoagulation for any mechanical circulatory support in the absence of complications on VAs, I mean, obviously.
And how do you target anticoagulation? What's your how do you monitor heparin?
We use antitennine level, so heparin level rather than APTT, and we want an antitennine level of 0.3 to 0.5, unless we have concomitant bleeding or severe thrombocytopenia or any other problem.
And this would be the same protocol as in ECMO mono patients? Okay.
Yes, exactly the same, just that you won't have the extra purging line of the glucose going with heparin through the purging line of the Impella.
And the other question was about how do you rule out that hemolysis comes from ECMO, either or Impella for the other part?
Yeah, so I think we have enough experience with ECMO that if you don't have suction events, if you didn't have problems cannulating, and if your ECMO circuit looks healthy, that we look at twice a day, you can become relatively confident that you can identify hemolysis coming from the oxygenator. without problems. Usually nowadays, if you have hemolysis in a patient on Impella, I would tend to be inclined to think that it's coming from the Impella. We will do immediate echo to make sure that the position is right. And usually what will happen is that it will be to decompress the ventricle, but the Impella in itself will also give you a hint. It will have having suction events, or the flow will drop. So it also gives you a hint of something that's going on. But I would think if you have Impella, the likely scenario is that your hemolysis is coming from the Impella rather than your VA ECMO.
Okay.
Providing you have a healthy oxygenator, obviously, not an old one. Yeah.
Now, with respect to the practical management, what would be your regular choice? I understand there are different models for Impella that can handle different volumes per minute. Do you have a standard approach? And what would be your presumably regular flow rate that you would think most patients would be well going with?
So we use Impella CP when we're using a femoral approach, a percutaneous approach, and we use an Impella 5 when we're using an axillary approach. For Impella, I would say most of the times it will be an unplanned procedure, so it will be an Impella CP through the groin. Impella CP can give you up to 3.8 liters per minute of flow, but you don't need that usually for Impella. So we will start at P2, P3, and we will echo the patient and make sure that the ventricle looks happier, less distended, and that the end diastolic volumes are coming down, the MR is getting better, and there's less smoke in the ventricle. And maybe a flow of 2.5, 3 liters will be enough to decompress the ventricle. It will also depend on the circulating blood volume of the patient, the initial diameters of the ventricle, but I would say probably a much lower flow than the ECMO flow. And it will also depend on the residual pulsatility of the left ventricle, on whether the patient is able to eject at all, or whether all the work will be done by the Impella. But lower flows, lower speeds to avoid hemolysis, that's a way forward in the beginning of using Impella, I would say.
Okay. I have a couple more questions there from all different aspects. There's one, Scott Weingart asked if you have any experience if this can be included into an ECPR strategy, because obviously some colleagues do so.
Yeah, so we've done it quite a few times in the last year on ECPR. We had a young patient with a venous air embolism, waiting a heart transplant, had a venous air embolism post line removal, and we did ECPR on him, and it was obvious that he wasn't going to open that aortic valve given the previous history. So we did Impella on him, and we've done a few ECPRs in the last few months on patients with large anterior MIs as well. One of them as a bailout strategy, the Impella, so a few hours later or a few days later, and another one, the interventional cardiologist who inserted the VA ECMO with our colleague intensivist measured the end diastolic pressure. Post ECMO insertion, it was sky high, so they went straight away to insert an Impella. So yes, we do it on ECPR as well.
Okay, so there's a principal question on the suitability of the technique versus other techniques. That's Daniel Herr from the University of Maryland. He says that they have used the ASD technique with a cutting balloon, and I understand that they see this is one intervention which costs less, is much easier, as he says, considering his center's experience, and it allows for patient mobility in these patients, especially those who are waiting for a heart transplant. Apparently not every center who will be able to do Impella will also be able to offer that kind of intervention. If you had the chance to decide between either, what would be the pros and cons from your perspective?
We don't have the ability to perform intra-aortic septal septostomy in our center 24/7, and we don't do it. That's why, and we have a good experience and a good learning curve with Impella. So I think that's why we do it here. I think a good atrial septostomy is a very good way of decompressing the left ventricle as well. You need to have the availability of an interventional cardiologist 24/7 to do it, and experience one, because but we don't have the ability in our center.
Yeah, and I, if you have been joining previous EuroELSO webinars, we had already sessions on LV venting, so there will definitely be centers who are very well experienced in these techniques and may apply them safely with good outcomes.
Mm-hmm.
We are coming to the end of the webinar. Maybe a very few more questions. Do you have experience, or are you aware of centers who do have experience with implementing Impella at the bedside, so not in the theater?
No, I don't have experience. My experience, our experience is that the malposition is very frequent, and you need fluoroscopy and combination with echo, because sometimes the I think the fluoroscopy is basic to it gives you a hint on when the Impella is getting tangled in the anterior leaflet of the mitral valve. When that happens, is a big problem, is a recurrent problem, and it causes hemolysis and malfunction of the device. And I think fluoroscopy is basic to do that. We don't do bedside Impella insertion. I personally think that you need fluoroscopy and to do it, to insert it, and immediate echo on arrival to ITU. And I don't know of other centers doing bedside Impella insertion. We definitely remove them by the bedside, but we don't insert them by the bedside.
Do we have a special closing device, or
Yeah.
You do?
Yeah.
Okay. So at that point, I once again really greatly would like to thank you for your excellent presentation, for the great discussion, for your expertise.
Thank you.
I personally, I wish you all the best for the exciting things to come. Private
Thank
life.
you.
All the best wishes from that side.
Thank you.
For our participants, if you came in late, if you want to review some things, in a couple of days, you will find a recorded version of this webinar on the EuroELSO website or on YouTube. And we thank all of you for joining today, to staying with this exciting offer from EuroELSO. And we hope that all, or at least most of you, will be able to join us at EuroELSO in London, planned as a face-to-face meeting, and we are very hopeful that this year will indeed happen, and we can finally meet each other again, May 4 to 6, 2022 in London, EuroELSO annual meeting. And with this, thank you very much again for joining, and never forget, you're only safe if your venous line is blueberry and your arterial line is cherryberry. Have a great day, and I see you next week at the proning webinar for adult patients on March 10th with Matthieu Schmidt. Thank you for joining today. Thank you again, Clara, and have a great day. Bye-bye.
Thank you so much. Bye-bye.